Good afternoon, everyone. For those who don't know me, I am Stephen West, Chief Strategy Officer at Shields, and I'll be facilitating today's discussion, which is focused on the reopening and moving beyond COVID. As we all know too well at this point, the COVID-19 health crisis has completely changed the lens through which we operate, both personally and professionally. And as members of the broader healthcare community, we wanted to spend today's conversation reflecting on both the previous and the ongoing efforts of our hospital leaders, while also collectively exploring new ways to respond to the crisis, adapt to the evolving environment, and grow through the new normal. For those who are not familiar with Shields, we partner with health systems to build and expand integrated specialty pharmacy programs. And over the past 3.5 months, we have been continually evolving our operating model to navigate through this changing landscape. And most importantly, ensure that our patients receive and remain adherent to their medications. Through those response efforts, we were in constant dialogue with our hospital partners to explore new ways to support them and adjust our approach to helping them. And as a result of those conversations, we thought it would be great to introduce two of our long-standing partners whose organizations have been fearlessly leading our communities through this crisis. So on today's webcast, we're going to hear updates from Dr. Eric Dixon, the president and CEO of UMass Memorial Health, Dennis Chalk, the former CFO and treasurer of Baystate Health, and Tanya Menchie, our director of public policy at Shields, who's also been simultaneously leading our efforts to build HOSP, the Hospital-Owned Specialty Pharmacy Alliance, which she'll be sharing more on later in the presentation. We'll hear a brief presentation from each attendee, followed by a Q&A period. For those who are not familiar with the Global Meet platform, you can submit your Q&A and responses will be aggregated by our team on the phone, and we'll respond to those at the tail end of the presentation. So without further ado, I'd like to introduce Dr. Eric Dixon, President and CEO of UMass Memorial Health, the largest nonprofit health system in central Massachusetts with 1,700 physicians, 14,000 employees, and $2.6 billion in annual revenue. Most importantly, we're proud to consider Dr. Dixon a longstanding partner of the Shields organization and a mentor to everyone on the team, and we're excited to hear his update today.
Great. Thank you, Stephen, and thank you to all of you for allowing me to present today and talk about something we're very proud of here, and that's our specialty pharmacy program that we do in partnership with Shields. I'm going to focus today mostly on talking about strategic levers as we respond and really recover from the COVID crisis, and what's different about our organization because we have the integrated specialty pharmacy. And we are strategically making very different decisions because of the specialty pharmacy program being a part of us. And so as we get along through the presentation, you'll understand exactly what I mean by that. So as most of you know, Massachusetts was hit very, very hard by the coronavirus pandemic. If you look at overall deaths or deaths per 100,000, Massachusetts was the third worst state in the nation, and obviously the United States being the nation hit the hardest. Here in central Massachusetts, our major city is Worcester. We were hit particularly hard for reasons we don't fully understand. Our overall number of cases per capita was almost twice that of the average of Massachusetts. And even if you look at the big urban cities to our east and our west, Boston and Springfield, we were hit significantly harder than them. The only thing that really went well for us is that the peak for us was later, and that gave us more time to prepare. So our peak utilization of hospital resources, if you look at this green line in that graph, was May 1st, and our peak ICU number of patients was on May 11th. That's almost a month after New York and New Jersey hit their peaks. And we could watch what was going on there and respond. And our primary way of responding was to build surge capacity to be able to manage the patients that we've seen. This graph here shows the number of ICU patients. That big, long orange graph is the number of patients, 130 in our medical center ICU. These are adult patients only. We only have 95 adult ICU beds. So we had to go and find areas across the medical center, across our healthcare system, to be able to take care of patients, ICU patients that needed to be in negative pressure facilities. And we really went right to the brink in terms of the capabilities of our healthcare system. We were running at 155% of our standard ICU capacity on May 11th, the date that's shown here. Thankfully, our partners in Baystate were prepared to take some of the patients from us if necessary. We never got there because their peak had been almost 2 weeks earlier. So, the team did an amazing job preparing and then responding for this. And I think because of that, we had a relatively low mortality. About a third of our patients that ended up in the ICU expired. That's significantly better than the numbers we're getting from other countries and other hotspots like New York and New Jersey. Overall, we've taken care of about 1,600 patients with COVID. The vast majority of them are home with their families now, where we want them. Now, there are many reasons I think that our mortality was low. We were number 7 in the world for enrolling patients in the Reimagine trial. We've treated almost 200 patients with convalescent plasma. Those are probably the 2 most effective treatments for COVID. I could add dexamethasone onto there now as well because of some recent trials. We did those things early and it helped us with the mortality. We also did some things to prevent having to ventilate patients. Our strategy was to ventilate patients as a last resort, put the endotracheal tube in, and so we used high flow nasal oxygen, including the CPAP helmet shown here, to try to bridge people past needing a ventilator. Because once they need a ventilator, they're paralyzed, bad things happen, and their recovery is going to be greatly slow. More than anything else, it was our people and their flexibility that got us through this. And this is one of our proning teams. And if you don't know, prone means to be on your stomach, on your face down. And that is the best way to ventilate a patient with COVID. Well, that means you have to turn people back and forth from their back to their stomach without losing that critical endotracheal tube. If that tube is lost, the patient's as good as dead. We didn't lose a single tube. But these are people, and some of them were just out of nursing school, that volunteered to turn patients with heavy viral loads, and just amazing in terms of their willingness to do something out of their scope of comfort. Now, I'll tell you, there's only 2 things that financially went well for us during the management of the COVID crisis. The first is we're self-insured, and our employees' costs for care went down because nobody was going to the hospital for care, and people were putting off care. But the other thing is that our specialty pharmacy revenue continued to come in because we were filling prescriptions that had been written months earlier, and that revenue stream was absolutely critical in keeping our cash stores up. The other thing that we heard from our patients is a lot of folks attached to providers that didn't have an integrated specialty pharmacy program. There was a loss of connections. How do I get my prescriptions filled? And a lot of work from the docs, some of which were redeployed for us to a field hospital in a convention center. Well, they're not doing the prescriptions. There's no connection. Our liaisons maintained those connections, and some of our patients called it, life-saving. And so I would say that, one of the things that worked best for us during the response phase was having that integrated pharmacy solution. Kept us financially going at the same time as it maintained that connection for us and with the patients. So now as we move into recovery, I always remind folks that cancer, heart disease, stroke, diabetes, they haven't gone away, and they kill a lot more people every year than coronavirus. And we have to get these patients in and seen and their cancer screenings done and their diabetic care done. They need us now, just like the COVID patients needed us during the response phase. So as we're starting to ramp up, we're really focused primarily on keeping people safe and how do we rebuild the business, because we've lost about $250 million in revenue because of this. And the federal government or the state programs aren't making up that. So we've got to find a way to rebuild this business. Massachusetts hospitals, even though they provided a lot of care, were particularly hard hit. We ranked 50th out of 51 in terms of receiving federal dollars on a per case of COVID. Rhode Island was dead last, 50th out of 50 states in the District of Columbia. So we've got to get this business going again so that we can take care of our patients. Now, this is one of the most important slides I'm going to show you, because this is what is different about us and other hospitals that have an integrated specialty pharmacy program. Our contribution margin on musculoskeletal services is about $17 million a year. Our contribution margin on diabetic care, this is just the outpatient clinic, this is not the downstream vascular procedures, is $17 million. And if you looked at Mass General, Brigham and Women's, any of our competitors, this isn't the case. They lose money on diabetes, and this is one of our most profitable service lines, as is rheumatology, MS, and other things. Now, as we reopen, if we want to try to grow MS and focus there, we're up against world-class competition, the Baptist, the Brigham, Mass General Hospital, and they'll invest a lot of resources in competing for that business. But diabetes, they're not 340B. So they don't have an integrated specialty pharmacy solution. So for us, this is strategically an opportunity to say, we can get this business, we can own this book of business for the region with a relatively small investment. And it's all because of the 340B. Our contribution margin for diabetes is basically all on the 340B impact, and because we have the specialty pharmacy with integrated liaisons. So as we work to recover, a big part of our recovery is trying to get patients through, get their care that they need for diabetes, MS, all of rheumatology, HIV clinic, and already in our first couple of weeks of recovery, leveraging virtual medicine, telemedicine, we're at 120% of our previous diabetes volume. So this is very different. Now, MS is at 75% of its pre-COVID volume. And there are services for us now that are very, very profitable, where virtual medicine makes all the sense in the world. It's really hard to do a knee exam through a video visit. By a diabetes exam, interaction with the patient, most of the data they can share with you, and you're talking, it's a lot of education through patients. So, we're taking advantage of the strategic niche, and we're going full throttle at this book of business where we have a heavy specialty pharmacy use to try to grow that during the recovery phase, instead of those books of business that everyone else is trying to get. Neurosurgery, spine, ENT, all the procedural based stuff. We'll work that as well, but this we're going to work harder because we think people are going to leave that for the easy picking. If we look into what goes beyond recovery, how do we reimagine the organization? What's changed forever? We all have a lot of questions about the future. Will we ever have the volume that we had before for procedures? I'm an emergency physician. I still practice emergency medicine. Our volume in the emergency department last week is down 25%. Emergency department. So, is this going to change healthcare forever? And I think the answer is yes, but I think it's going to change it hopefully in a positive way in a few focused areas. Virtual medicine. We're all talking about virtual medicine, and people say we hope they continue to pay at the same as an office-based visit for virtual medicine. What I would say is, even if they don't, what we've learned in those cognitive areas, MS, rheumatology, right, diabetes, is that even if you don't pay us for the visit, we can be very profitable in providing care to that individual, and I can better leverage my diabetologist and make it all back up on the specialty pharmacy book of business. And for those of you that have a 340B program, this is not something where the wealthier hospitals that take care of a low governmental payer percentage are going to go after. It's there for the taking. It's low-hanging fruit. And what's really what you're looking for in strategy? What is the thing that I can do that, and do in a way that will make us profitable so that we can continue the mission of the organization that everyone else is just going to ignore? And I think many of those services that lend themselves most to virtual medicine, it's going to be, you're going to have that integrated specialty pharmacy on to make that work. And so we're banking heavily on virtual medicine, even if they take the payments away, and for those cognitive specialties. The other thing that's very clear is that with the downturn in the economy, cost is going to matter, total medical expenditures, right? Everybody's going to be looking for the lowest cost product for their employees. As people are cutting costs, they were looking for it before, they're going to be looking even harder. And what our specialty pharmacy has done for us is allow us to manage total medical expenditures. And that has nothing to do with the price of the drugs, and it has everything to do with the medication adherence. 13% of total medical expenditures comes from not adhering to your medications. And what happens with our specialty pharmacy and the liaison and the call center is we get better medication adherence, and things like HIV viral loads go down, transplant rejection rates go down, hemoglobin A1C levels go down. And because of that, TME goes down. So if you look at the red line in this graph, here's our starting point, 2016 for ACO, matched patients. We have 50,000 patients in the Medicare ACO. The red line is what happens to total medical expenditures when you put people on the integrated pharmacy program. They go down. And the blue line is what happens normally. They go up over time. And so as we work to deliver greater value and move to more risk-based contracts and have to really prove that we're reducing TME, one of our key strategies is to use the integrated pharmacy connected tightly with our ICO group to drive down TME. And this data we hopefully will get published in JAMA soon. We've got that submitted, and matching the great results that we have on reducing TME is the improved quality outcomes for patients that are part of the integrated pharmacy program versus those that are not. I hope, if nothing else today, you've learned a couple of key strategic levers you can pull if you have an integrated specialty pharmacy program that is not available to your competition. And for me here in Worcester, I'm up against world-class competition. And so I have to look for those things that we can do and be successful and generate margin to support our mission, that the Mass Generals, the Brighams of the world are going to leave for me to pick up, or not fight me as much on those things. And that's not neurosurgery or musculoskeletal procedures. That's in and around those cognitive specialties where our liaisons are tightly embedded. Thank you.
Dr. Dixon, thank you. That was an incredible presentation. Look forward to diving in a little bit more detail in the Q&A. I'd now like to introduce everyone to Dennis Chalk, the former SVP, CFO, and Treasurer at Baystate Health, a $2.5 billion integrated healthcare delivery system in Western Massachusetts, which includes 4 acute care hospitals, 750 physicians, and a health plan with more than 160,000 covered lives. Looking forward to hearing Dennis's perspective as he reflects back on COVID and how specialty pharmacy played a role in the recovery.
Great, thank you, Stephen. So this afternoon, I'm going to talk about the financial impact of the coronavirus on the not-for-profit hospital sector and how things might change going forward. But before I do, I think it makes sense to really review the financial status of the hospital sector prior to COVID. And if you think back just 4 months ago, the economy was doing quite well. We had strong growth in corporate earnings and GDP. We had low inflation, low unemployment, low interest rates, and strong investment returns. So the economy itself was doing quite well. But when you look at the healthcare sector, particularly the hospitals, it was much different. Hospital and health system financial performance was at an all-time low at about 1.7% operating margin. And most will tell you that you really need to be in the 2.5% to 3% operating margin range in order to be sustainable. Hospitals are very capital intensive and they're very people intensive. And so in order to afford the capital projects and to fund those capital projects, you really need an operating margin of 2.5% to 3%. So the median at 1.7% obviously fell well short of the long-term sustainable margin that's required. So what's been happening to cause this deterioration in terms of operating margin over the past several years? There's been a number of factors that have contributed to this. First of all, if you look at the revenue side, payment rates really have not kept up with the expense inflation. So if you look at revenue, we have minimal rate inflation, particularly from the government payers, so Medicare and Medicaid. We're not seeing any significant rate inflation from those payers. And in some cases, we're seeing rate declines from particularly on the Medicaid side. And for many hospitals, the government business accounts for about 65% of the volumes for those organizations. So when you have 65% of the revenue being flat, you're really dependent on the commercial business for any significant rate increases, and that becomes very challenging, particularly in states where there's a lot of regulation and control over commercial rate increases, which was the case in Massachusetts for several years. On the expense side, however, we're seeing significant inflation. We're seeing salaries going up 3.5%, 4%. There are nursing shortages, there are physician shortages, all contributing to the inflation on the expense side. And for most hospitals, salaries and benefits account for more than 50% of the expenses, typically more like 60% of total expenses. In addition, we're seeing growth in other expenses such as pharmacy costs and borrowing costs and so forth. So if you look back over the past several years, we're seeing expense growth outpace revenue growth. There's other challenging trends as well. We're seeing profitable inpatient procedures moving to outpatient. Orthopedics is a prime example here. So we're seeing a lot of hips and knees and other procedures going to the outpatient arena, where typically the profitability is much lower. We're also seeing inpatient cases moving to what's called observation status. I'm sure the finance folks on the call this afternoon know all about this, but typically now about 25% of cases are now classified as observation, and they're paid at a level that's much, much lower than traditional inpatient cases. And that's, again, putting pressure on the revenue side of the equation. Also, we're seeing a growing number of employed physicians. So if you look at most health systems, they employ a significant number of physicians. Hospitalists are typically employed, oftentimes emergency room physicians, radiology, anesthesia, and so forth. And typically when health systems employ physicians, they lose money on those physicians when you just look at the physician entity itself. And in fact, when you look at Massachusetts, every system that has an employed physician group is losing money on that group on a standalone basis. And then finally, the other challenge to the hospital sector over the past several years has been competition from new market entrants. These are typically for-profits that are coming into the market to pick off the profitable procedures that hospitals have enjoyed over the past several years. So all these factors are leading to a decline in profitability for hospitals. And as a result, hospitals have had to react, and they're doing so in many ways. They're joint venturing with for-profit partners who have specific expertise. So when you look at those sectors, we see hospitals joint venturing with behavioral health hospitals. Most hospital systems will lose money on behavioral health. However, the for-profits have figured out a way to actually make a little money and serve a greater portion of the population with specific hospitals designated for behavioral health. You also see joint ventures with radiology groups and freestanding surgery centers. All of these things have contributed or helped hospitals and prevent them from losing all the margin associated with those cases that they previously enjoyed. Hospitals are also undergoing a number of financial improvement initiatives. Many consultants around the country are busy helping hospitals find ways to either enhance revenues or reduce expenses. Many hospitals who realize they cannot play the rate game anymore, they just don't have the power in the marketplace to play the rate game, they're pursuing risk contracts, hoping to make money by reducing utilization, providing higher quality care at a lower cost, and thus sharing in some of the positive risk-sharing opportunities in risk contracts. And then also investments in technology. A lot of health systems are forming innovation centers and trying to find ways to capitalize on the significant amount of dollars that are coming into the healthcare sector from private equity firms and others. We're seeing many new companies popping up, all wanting to get into the healthcare space. And for hospitals, it's really important that they take advantage of these opportunities and find ways to partner with these new initiatives. At Baystate, we had a joint venture on the radiology side for many years. We also have entered into a joint venture for behavioral health. We had a joint venture around urgent care, and we had our partnership with Shields Specialty Pharmacy for several years now. And as I talk to other hospitals, 340B hospitals, their pharmacy program is contributing a significant amount to the bottom line margin of those systems. I know at Baystate and in many other areas, many other systems, the margin produced by their pharmacy programs could exceed 50% of their total margin easily, and sometimes going up even more than, a higher portion than that. So it's important that for health systems to really take advantage of the expertise that's out there and to partner with these organizations in order to make a reasonable margin going forward. So now I'm just going to touch base on the impact of COVID. And, all you have to do is read Becker's Daily, and you'll see the impact that COVID has had on hospitals across the country. In mid-March, elective surgeries and procedures were suspended. So we saw a significant decline in hospital volumes. And the volumes that left were for the most part, more profitable volumes. So we saw orthopedic surgery go away. We saw endoscopies go away. We saw many of the electives just disappear. And for many hospitals, the COVID cases in total were less than what the hospital traditionally had seen in terms of medical surgical volumes. And so overall, hospitals saw a large decline in total volume, overall reductions in the 40 to 60% range for many hospitals. When you look at the freestanding surgery centers, of course, they were down significantly, some down 90%. And radiology also down significantly, about 60%. And while the revenues declined, the operating expenses actually increased because of PPE. There's many examples of hospitals having to spend significant dollars on PPE, as well as capital expenditures related to the COVID virus, and also being faced with significant shortages in revenue. So as the shutdown lengthened, many hospitals furloughed employees. Some did so without pay, some did so with pay, but significant reductions in employed staff, and hospitals then began to announce major losses, and we have many examples of those losses that have been reported recently. For example, Mass General Brigham posted a $1.6 billion net operating loss in the first quarter. That's really prior, that was January through March, and they're projecting a $2 billion loss for the year. This is after receiving $314 million in federal grants and funding related to the virus. They plan to cut executive pay by 25% for a year and senior leadership pay by 5 to 20% for a year. Other examples, Sutter Health had a $1.1 billion operating loss in the first quarter and spent more than $39 million in PPE supplies getting ready for COVID. Tower Health in Pennsylvania is cutting 1,000 jobs, or 8% of its 12,000 employee workforce, after losing $91 million in the first quarter of the year. And all the major hospitals and systems are reporting major losses. We saw Mayo come out, Cleveland Clinic, and others. And so it's been pretty widespread across the country and hitting all states. Kaufman Hall said the median operating margin for hospitals was a negative 29% in the month of April. So certainly that's a significant challenge for organizations. And while the federal and state dollars offset a portion of the losses, as Eric mentioned, they certainly didn't offset all the losses. I think the only thing that's been good news is that the cash advances that came from CMS helped stabilize the cash position for now. But those cash advances have to be paid back. I think the final rules in terms of the length of time over which those advances have to be paid back is being determined. I think the original plan was over 3 months, but hospitals are asking for a longer window to repay those dollars. So hospitals still are okay in terms of cash for the most part, but again, as those dollars get repaid, that's going to be a challenge. The rating agencies really are having a hard time trying to figure out what to do about all this. They are postponing reviews of some hospitals, recognizing that, this is a very unusual situation and they're not sure, and hospitals themselves are not sure what it's going to look like after this is all over. So there's been some delays and postponement of rating agency reviews, but certainly they will be back next year trying to make sense of all this. And again, their primary focus is the institution capable of paying down its debt, paying back its debt, and that's how they really judge organizations. So it's really based on current cash and future cash flows going forward. So what is it going to look like post-COVID? I mean, it's very difficult to guess at this point in time. The economists a few weeks ago said they expected unemployment across the economy to increase 2 million people, and then actually was reduced by 2 million. So it's difficult for any of us to really estimate what might happen going forward here. But certainly hospitals are beginning to budget for FY 2021. And there are a number of questions, major questions. What will be the speed of the economic recovery? Is it going to be a U-shaped? Is it going to be a V-shaped? And how might that impact hospital volumes? As Eric mentioned, ED visits are way down. Many other volumes continue to be down. How quickly will they bounce back, or will they bounce back? What will be the new normal? Are we going to see ED visits continue to be low, and perhaps urgent care visits tend to jump up? Are we going to see primary care visits bounce back like they did, or again, is that going to be volume that might go to urgent care? So a lot of questions. I know many hospitals are budgeting in the 80 to 90% of volumes pre-COVID, and adjusting expenses accordingly. But again, a lot is unknown at this point in time. Rating agencies will be back, as I mentioned, the next year, and it's very likely that downgrades will increase. I do not think that the cash position for health systems after this will be as strong as it was prior to the COVID virus hitting us. And we all know that the federal and state budget challenges are significant, and particularly as it relates to the virus and the number of dollars that the state and federal government has had to pay to help us get through this pandemic. So the federal and state budget challenges will continue to pressure Medicare and Medicaid rates. We probably expect, or we'll probably see continued hospital mergers and acquisition activity going forward, and it will likely increase. We saw it just the other day where Aurora Advocate, who plans to now merge with Beaumont, and there's been a significant merger and acquisition activity in the Carolinas. So we expect that to continue. And we also expect joint ventures and partnerships to grow. And again, the partnership that Baystate's had with Shields Specialty Pharmacy is very similar to what is happening at UMass. It's been a great partnership. It's helped not only improve our margin, but it's also improved patient satisfaction, physician satisfaction. And when you find opportunities that improve both financial results and patient and physician satisfaction results, there's not a lot of those that are out there, and when you find them, you certainly pursue them. So I think my time is up. I will end here, and certainly be happy to answer questions as we go forward.
Thanks, Dennis. Really, really appreciate you walking us all through that. And I guess to wrap things up, I'd like to introduce everyone to Tanya Menchie, who Tanya is our Director of Public Policy, and she leads government affairs, policy guidance, and other related strategic initiatives for the Shields organization. And prior to joining us, she spent 15 years working in policy for the U.S. government. So we're really excited to introduce Tanya and have her share her perspective, and also introduce the hospital-owned specialty pharmacy initiative that she's been developing over the past several months. And with that, I'll hand it over to Tanya.
Thanks a lot, Stephen. So I'll just give you a quick overview. This is the Health System-Owned Specialty Pharmacy Alliance. It is a new trade organization that is being launched this summer. We call it HOSP. And HOSP has developed out of a few things. As the integrated specialty pharmacy model has grown, there hasn't been a trade association that's really kept up with the needs of the industry. There are other platforms out there, but there's not one that's just focused on the needs of this industry. We also have seen that systems that have integrated specialty pharmacies really can see the benefits of their integrated model. They can see the better patient outcomes. They can see the impact on their revenue. And so they're really best positioned to talk about this industry and what the benefits are. So this is HOSP. The mission is really focused around a couple of things, specifically sharing best practices, sharing information, and then advocacy for the organization. It's a nonprofit. It's been incorporated in Delaware as a 501c6, which is industry trade association. It will be governed by a board of directors that will have their first meeting in a few weeks, and then it will launch shortly thereafter formally. The intention of the organization is to be totally independent, to be self-sustained, and to really work to the benefit of its members. And I'm going to run through just a couple different activities that have been discussed for the organization. Like I mentioned, best practices development, which can range from informal learning, informal sharing among the members, to more formal certification programs, accreditation. All of these things have been mentioned, but ultimately it will be up to the board and the members to decide where they want to go. Again, like I mentioned, the members are really the best position to promote their own industry, so promotion of the integrated approach. And then finally, advocacy on issues like 340B, access to limited distribution drugs, access to payer networks, and other outreach and sponsorship activities. And we envision that there would be coalition building with other existing organizations where there are common interests. So that's it. I just want to give a brief preview. As I mentioned, the formal launch will happen later this summer, and we look forward to our organization getting off the ground and all the members getting to work. So I'll stop there and turn it back to Stephen for Q&A.
Thanks, Tanya. Appreciate that. We're incredibly excited for the launch of HOSP, and I think we see this as an incredible opportunity to create an alliance of both Shields members, non-Shields members, really kind of bring together the market of health system participants in what is now becoming the fastest growing area of specialty pharmacy, and really create a platform to advocate on their behalf. So really looking forward to that launch in the coming weeks. So with that, I figured we'd shift over to the Q&A section. And I think we heard some fascinating perspectives from Dr. Dixon, Dennis, and Tanya. And we were fortunate to have several questions come in throughout the presentation. And I'll start with Dr. Dixon first. One of the slides that really stood out was the concept of the contribution margin of some of these specialties that maybe historically would have been considered loss leaders or break-even programs. And what I thought was fascinating was the way that you demonstrated how, with the integrated specialty pharmacy program, these disease states like RA, MS, oncology, diabetes, all of a sudden become really profitable growth drivers of the business. So I was curious to get your perspective on, historically, has UMass been able to expand your service offering in Worcester and Central Mass, leveraging the funds from the broader program to grow those service offerings?
Yeah, absolutely. And I think, Dennis could talk more about this. When you're in part of a mission-based organization, you try to grow your profitable service lines such to subsidize the unprofitable service lines, your mission-based activities. And there's always a long list of additional things we'd like to do to be able to serve this community. And, the problem with trying to grow your profitable service lines has historically been it's the same profitable service line for everyone, right? And so now you've got to compete. You say you want to grow by 5%, well, your competition wants to grow by 5%, and as does the other person. Somebody's going to lose here. And With the specialty pharmacy, we can pick service lines targeted growth that others aren't trying to grow. So if we say we want to grow diabetes by 10%, that it can, and we're much more likely to be successful because nobody else is going after that business, which creates the revenue necessary to be able to support some of the mission-based activities. And you know, the one other thing I would have to say about growth is the CFO always wants more of these profitable service lines. That doesn't carry the day. For us, the chief quality officer wants more because we're seeing better outcomes, and the president of our ACO wants more because they've seen a drop in TME. Probably the most amazing thing and the surprise to me with this program, I started as president of the medical group, is the physicians want more in the clinics and the nursing staff want more in the clinics because the integrated liaison takes care of all this pre-authorization stuff. They often have patients that can't get the drug. They find ways to get them free medications, and they make life easier for the clinic staff. And that is what is driving the growth. When you have clinics saying, I want more liaisons, I want what transplant has, and that's how it started out. How come the HIV clinic gets all those liaisons in there and we don't have as many of them? And so because they recognize that it's taking work off the back of very, very busy providers. And I would say the key to the growth really for us has been leveraging the great service that the liaisons provide when they're in the clinic and making life better for the patients and for the providers.
Dennis, any thoughts on that question as well, just from your experience and how it may be able to change your perspective on certain service lines to expand within Central and Western Mass?
Yeah, absolutely. I think, our experience and approach has been similar to UMass's in that we're really focusing in areas we didn't really focus on prior. And, looking at diabetes, for instance, and it's great when, as I mentioned before, when you can really focus on these areas and help make physician lives easier, make patients' lives easier, increase the quality, and reduce the costs. And I think, it really creates a win-win-win situation.
That's great. And Dr. Dixon, I wanted to follow up on a comment you made earlier when we were looking at the improved outcomes for patients and the study that you did with the UMass ACO that is currently being published with JAMA. Did those findings and the information that you've gathered through that program increase, I guess, the organization's appetite to take risk on specialty patients?
It certainly does, because you've got data now that supports a lower TME. And we've run an ACO for a while now in multiple different areas. And it's that 5% of the population, 10% of the population that's using up 50% of the healthcare resources. That's who you have to manage, right? Depending on whether it's Medicare, commercial, or Medicaid, there's different levers that you're going to pull. But think about those patients, the high utilizers of care. What is the common thing between all of them? They're on a lot of medications. So we actually are, the way we work our ACO care management program, they're employees of a different Shields group, but we have them integrated in, and we purchase that service from Shields because we want them totally embedded in the specialty pharmacy program, seeing that, because the crossover between your high utilizers of care and your specialty pharmacy patients is very significant if you think of the Venn diagram, because high utilizers of care are on a lot of medications and their outcomes are medication adherence sensitive. So the long term for us as we build out the ACO and we manage risk is we've got to have those patients integrated into the specialty pharmacy program, because we know that's going to be a big lever for us to reduce the costs. And because the price for the drug that the ACO is paying is the standard retail price, it doesn't increase the cost for the medication per se, and the hospital can make a margin on the sale of the drug. So, yeah, a lot of people get into this and they're focused on, you want to sell fill as many scripts as possible. But the real win here might be on the quality and the reduction in TME piece, especially coupled with virtual medicine now that has opened up to us. As I look to the future, this is a pillar of our population health engine, and not just some pharmacy program that sits on the side that happens to be profitable.
That's great. And Dennis, I know that your organization has managed nearly 200,000 covered lives over the years through Health New England. And I'm curious, any thoughts on, does the offset that the lower MLRs created for health systems that had large health plans, do you think that's going to be a driver for health systems to also take more risk moving forward?
Well, Baystate's been involved in taking risk on the provider side for quite some time. We were involved with, the Medicare Advantage program on the provider side, and also the Next Gen program, where we had 60,000 lives in Medicare Next Gen. We participated in the Medicaid ACO as well. And so on the provider side, we had about 150,000 members at risk, and then on the plan side, another 160. Some of them overlap, but many were different. And so we've been looking at ways to, better, improve quality and reduce costs for many, many years. And certainly the pharmacy program working with Shields has helped us, again, improve our quality and focus on those patients, those chronic care patients who are heavily dependent on a number of drugs and a lot of specialty drugs as well. So yeah, I think it's been certainly a win-win, and we have been able to include our community physicians in our programs and help take a lot of the burden off of their offices as well by having them participate in our specialty pharmacy program. So I think it certainly has helped us over the years, and I think it will help others as they pursue risk contrast going forward.
Thanks. So another question for Dr. Dixon. As certain areas of the country see a resurgence in COVID-19 cases, any advice for healthcare providers and leadership in terms of how best to prepare for another wave?
Yeah, this is a little bit scary to watch what's going on in some of the mostly southern states. And we're looking at this, we're down below 50 cases. We feel like we've made it through, and then you're seeing it start to come up again. I think what I would say to folks is we won't get surprised the way we did last time relative to this. It is predictable that if I look at our % positive test rate today, that that will tell you where your 3 weeks from now, where your number of hospitalizations will be. And then almost 2 weeks after that is your peak of ICU. So it's the proverbial pig going through the python. First is the low acuity illness increases. Then there's the med surge level hospital care, and then there's the ICU care. And watch that leading edge indicator of what is your positive test rate. We do almost 1,000 coronavirus tests a day now, and we're running at 2% or less. And that's versus 30% in terms of positive test rate before. And that positive test rate was April 18th. And then, 2 weeks later, we saw our peak in hospital utilizations. 3.5 weeks later, we saw our peak in ICU beds. That just keep an eye on that. And if that starts going up, you need to prepare for what the surge that's coming. And probably for the local and state governments, you need to start to shut down things that you were doing before because it's becoming unsafe. We didn't have that leading edge indicator before with coronavirus because we didn't have access to testing. And so I do think that there'll be a second surge. I think it won't surprise us. It really caught New York off guard. I think we'll have some leading indicators, and hopefully people will continue to be safe. And as healthcare leaders, we have to try to push the rhetoric away that this was some kind of conspiracy. This was real people dying in our hospitals at rates we've never seen before, and we'll need to be vocal about it.
Thank you, and appreciate everything that you and your team has been doing on the front lines to support our response effort. So question for Tanya. So on the HOSP initiative, is there an opportunity for HOSP to advocate on behalf of health systems, knowing the opportunity that 340B may present to offset some of the losses from COVID?
Yeah, it's a great question. With my experience working in DC on the other side, working for the government, I can tell you that when you get input on an issue, when there's advocacy on anything, if it's coming from one company or if it's coming from one hospital, it doesn't have the same impact as if it's coming from an entire industry. And so, HOSP, by just coalescing around an issue together and speaking as one voice, with HRSA, for example, if they're developing new guidance, HOSP will have the ability to speak with one voice around positions to, hopefully help shape whatever that guidance may be.
That's great. And I know your team is working with a number of different participants to reach out on behalf of them to clarify some of the recent updates around registration windows and telehealth. So certainly a lot of exciting insights to come around the corner. So I know we're up on time, and I wanted to thank each one of our presenters for sharing their thoughts on the future and reflecting on some of the lessons we learned from COVID. And really appreciate everyone taking the time, the input and the questions from the group, and look forward to continuing the dialogue over the coming months as we get back together on future webinars. So a big thank you to Dr. Dixon, Dennis, and Tanya for walking through their presentations today.
Thank you, Stephen.
Thank you.
Thanks, Stephen.